everyone go through this, and I know it did take a lot of time today, but we're all providing support and services to other people. And it really is important that we are checking in with ourselves, that we're being aware of the impact on our own mental and social well-being, and we're checking in with colleagues. I'm doing just as much support for my clients as I am for other therapists, for other colleagues, other professors, etc. So just really being aware of those pieces and making sure that we're also taking care of ourselves, because we cannot take care of anyone else. And I think the other piece is what I was hearing from a lot of you are the same things that our clients are going through. And bearing in mind that our clients aren't always going to have access to the resources that we're utilizing to manage that. So I just want to, I know I've used up a lot of time, but I just thought that was really, really important to stress in these times. So basically REAP stands for Referral, Education, Assessment, and Prevention. We serve older adults over the age of 60 and people who live in senior housing. Even if they're under the age of 60, we can still serve them if they live in senior housing. We also provide support for family members of older adults. So if you're caregiving for someone who's an older adult, we can still provide services for you. And we also provide informal and formal caregivers and the professionals who work with older adults. We call that technical assistance. So that kind of encompasses what our program, just kind of that overview of what we do. The purpose is to support older adults in the community, to maintain and improve quality of life, support independence. The main emphasis is on mental health and substance abuse. So really we're looking at those unmet needs of mental health and prevention for vulnerable older adults and their families. So really kind of looking at those pieces. We're short-term counseling. We're not crisis. We are not long-term. It's really that core social work, short-term solution-focused interventions, strengths-based, person and environment that really encapsulates what we do. So we provide some screening. We have 3 screens that are mandatory for us to do. One is an alcohol screen. One is the PHQ-9, which is a depression screen, and then we do the MOCA as well, which is a cognitive screen. And the idea is just not that we're diagnosing anyone, but it kind of gives us a sense of what might be going on and gives us some information. These are all evidence-based tools that we can then take and share with other providers. We provide assistance with connecting to community resources. We provide education, and we really work at prevention issues. We will, a lot of times we'll do some brief depression intervention, brief alcohol misuse intervention. So most of my counselors are bachelor's level. We have a few masters. I think I'm the only licensed clinical social worker. So we're not providing therapy, but we are providing therapeutic interventions. We do educational programs in housing and in the community around a variety of issues, from working with your provider to the winter blues to managing bullying, which we're seeing a lot of housing sites, and et cetera, et cetera. We offer consultation and collaboration with professionals as well. So again, short-term prevention and intervention, we provide up to 5 in-person sessions for most participants. And we have a few counselors that have been trained in an additional level of, at a higher level, I should say. And for those, they can sometimes offer an additional 6 sessions for people that are eligible for within a specific brief intervention. Usually it's around substance abuse. We are looking at making some shifts around that. We run parallel to the community mental health center. So we cannot see someone if they're already in the community mental health center. Usually a lot of times what we're trying to do is actually connect them to the mental health center or other community resources. So if you think of us more of like a catalyst, you know, we'll go in, we'll kind of see what's going on, and then as appropriate, we'll try to get that person connected to the right community resources. That being said, there are times when we might see someone whose family member is part of the community mental health center, and we can do that. So like, for instance, I have a client whose wife is seen by one of our psychiatrists. I can't see her, but he could use a little support around some caregiving, so I can see him, and I may eventually connect him as well. But for right now, we're just trying to assess and see what his actual needs might be. Let's see. We can see people whatever location is best for them. So a lot of times we will see people in their home, which I love because I get to actually see them in their home environment, and you're already 5 steps ahead when you do that. We can see people in assisted living. We can see people in short-term rehab, in the community. Met people at coffee shops before, that's fine as long as that's what they're comfortable with. I have sometimes people will come to my office. I cannot see them if they're in a long-term nursing home. We have seen people who are in the hospital. It really depends on what their comfort level is and what makes the most sense. But we have a lot of flexibility in this program that a lot of other clinicians just don't have. So that's kind of the long and short of it. So we're short-term, again, prevention-based. So we're not crisis, we're not bees. I'll talk a little bit more about some issues with that as a little bit later on. We're not appropriate for people who are acutely psychotic or incredibly medically complex. When in doubt, I'm always fine to do what's like a consultation over the phone. There may be times we might take a piece and say, well, I can do this piece, but this is the extent of what our role is. We have to be very careful around mission creep. But really kind of looking at those, how can we help prevent poor outcomes for our older population? So we are statewide, and one of the things that I find really interesting is that we are the only program that is statewide like this in the country. I have seen some other programs. I think Chicago has one based out of the hospitals that is just for Chicago, and it's a medical focused. Maine has one that's a very medical focused. And again, they're not statewide. I think it's just for York County. I just got a heads up around one in York that again is very small and it's just starting up. But we are the first in the country and we are statewide. We're staffed with clinicians in each of the 10 mental health centers. So each mental health center actually hires their own clinicians. I oversee the entire program. So the mental health center is part of our supports. We're collaboratively funded under New Hampshire Department of Health and Human Services, so Bureau of Behavioral Health, BEES, Bureau of Drug and Alcohol Services, and New Hampshire Housing Finance Authority. So New Hampshire Housing is actually where we started about 20 some odd years ago with just trying to offer some help around people in housing who are having issues with alcohol. And what they quickly discovered is what you knock on someone's door and say, hey, you need some help, stopping drinking. We weren't being very well received. But when we started to offer other resources, then they were much more likely to allow us to come in, and we were able to impact that way. We are free. We don't charge because we're funded. There is no charge whatsoever for services. And it tends to be kind of what we call like a soft hook, a soft entry point for people into the mental health system who may not really feel comfortable accessing mental health for a variety of reasons, but may be willing to let someone come in and offer some help with resources. I had a client who expressed that to me a couple months ago, where she's like, oh, I never would have come in to see a counselor, but was willing to come in and meet with me for a period of time, and it was very helpful for her. So again, we offer assistance and support for adults, their caregivers, and the people who care about and care for older adults, including professionals. So making a REAP referral, you can call ServiceLink, contact your local community mental health center, ask for a REAP counselor, develop a relationship with your local REAP program and contact them directly. I cannot stress how important that is, having those relationships. I had a great relationship with the REAP counselor in my county, and we did some really phenomenal work together. If you have any issues, you're not getting a response, give me a call, send me an email. More than happy to see what might be going on. One of the things I always like to stress is REAP is the core of social work. It is what social work really started out as. You know, we started in Chicago and Hull House and Jane Addams and working in the tenements, and it's that perfect, I think, coverage of, you know, I get to offer some clinical support, I get to do some community work, I get to do some advocacy. I'm not worried about, is this billable? I'm not worried about, do they meet criteria? It's, I'm here, what do you need? How do we work together? And how do I help connect you? And I get to think outside the box and I get to be creative. And we do some really phenomenal work because of that. We're not having to work within the constraints of so many of the systems issues that are out there right now. So it's work that I feel really passionate about, and I think is a huge asset to New Hampshire in general. So I'm not going to spend a ton of time on this, but I do think it's important. I've had to go over some data over the last few months, and I'm still in the process of interpreting it and looking at it. But one of the things that we're finding is that, and I think we've all talked about it in this at Pathways and in other places, is that there are some shifts that are happening within the state, demographically, resource-wise, et cetera. And we are starting to see that within REAP. So I think our last funding increase came, maybe 8 years ago. So we've been, our budget has been flatlined for the last 8 years, while the demographics that we serve have been increasing. And so again, this is very rough, but if we look at data from 2016 to this year, so and this year it's only 2/3 of the way through our fiscal year, so keeping that in mind. In all of 2016, the total number of cases that we saw, so we do direct counseling, person to person. We do indirect, which is a lot of phone work. A lot of times that's case collaboration. And then we do technical assistance. So I just looked at those three. So in 2016, the number of person to person visits that we did were 460, and we did 91 indirect. So those would be for each case. In 2020, we had 362 direct, but 199 indirect cases that we worked on. And the average hours in indirect for the direct were 5 versus 4 for the 2020. The number of sessions that we offered were 1,390 and 71, so it's around 2,000 cases overall. This year we had 842 sessions of direct and 256, about 1,000. And then our average sessions were 3 and 2. And then, but if you start to look, what I found really interesting was that we're doing more indirect work than we are actually doing direct work. And I think what we're finding is that the types of cases that are being referred to us are more complicated cases. So we're having to do a lot more case management and care coordination and being asked to step outside our scope. And the last couple of cases I had like that specifically, I was finding the same thing was happening with the Bs and the hospital social worker. And so I think, as I drill down into these numbers a little bit more, it's going to be really interesting to see what's happening. But what we're finding too is in 2020, these numbers are only 2/3 of the way through the year. So that's 2/3 versus an entire year. So we're expecting to go beyond what we did in 2016. And actually last year we were over budget. We're starting to see a shift in the average age, slight, but still, and the median age in 2016, 60 to 69. Now that's 70 to 79. And we're starting to see an increase in more caregivers as well. So again, very rough numbers, but I think just important to stress that those 2020 numbers are just for 2/3 of the way through the year. That's not the entire year that we're seeing.
And Marie, we are at time. I don't know how. Okay.
Okay. Yeah, I'll breeze through this just really quickly. So COVID-19, just again, being aware of social isolation, its increase in depression, anxiety, and other mental health issues. REAP and Bees, we're both seeing a decrease in referrals because of lack of connection with community resources. So really stressing as much connection as you can. Bees is coming out with a tool to do screening over the phone. So expect that to come out in the next week or so. I'll email this to Kelly so everyone can take a look at it, but just being aware that social isolation is disproportionately affects our older adults. So social distancing is important for them, but it has some really significant impact on their mental health, as well as their physical health. And it really is important to increase coping skills and strategies. And that there is a really some significant barriers to our older adults receiving treatment, fear of discrimination, seeing mental health problems as a weakness. So being aware of those barriers are important, and that loneliness does hurt, that it has an actual physical component that goes along with it. So we need to be aware of that impact, not just on the mental, but also the physical. And then these are just some of the disparities. Again, we talked a lot about our own coping strategies, but how many of those were ones that we have access to? Zoom, transportation, I can get out and walk, I don't have physical limitations, I can easily access resources, I can order from Amazon, I can order dinner to have it delivered, I can, there's so many things that we can do based on technology. But for some of our older adults, it's the phone. And I love someone else has said about letters. So when we rely just on that, it's we're leaving out a whole population. So we've moved to remote only support. We can open cases by phone. We're still taking them. We're offering more flexibility with the number of client sessions. We've made changes to our websites. We're doing weekly check-in with every current client and previous client if they want it. So usually they're about 15 minutes. And we're reaching out to community referral sources, just making sure that people know that we're here and what we're doing. We're increasing community awareness. I know Seacoast is going to be doing some Facebook webinars, so be looking for those, educating and offering technical assistance. This is just a chart that you guys can look at when I send it to Kelly. I think it was really important to be thinking about where we are within our own, again, kind of going back to that first exercise that we did and what we can do and what we, as we move forward. And then this is just a really important advocacy piece. So New Hampshire has made some changes in terms of coverage for healthcare or mental health care for telehealth, allowing phone sessions for a lot of private insurances as well as for Medicaid. Medicare, which is the bulk of my clients, has not made that shift. And so that's on a national level. So this is an opportunity where you can reach out. New Hampshire National NASW is doing a lot of advocating on this. This is our population that is most isolated, cannot get out, needs the support the most. REAP, we are offering some support, but we can't meet everyone's needs. So making sure that they do authorize those telephonic sessions so that clients can still access services, even though they cannot leave or they may not have the technology to do a Zoom or DoxyMe or any of those other sort of telehealth services. So